Good morning. Sorry to interrupt. Welcome to the 2018 Curtis R. Holzgang Visiting Scholar Lectureship. I am Nick Cockler, Regional Director and Endowed Chair at the Providence Center for Healthcare Ethics. A few announcements before we get started. If you haven't done so already, please silence your cell phones and pagers. Medical grand rounds will go until 9 a.m., including some time at the end for Q&A. We will then pause to allow time for those who need to leave before transitioning to the extended Q&A period, which goes until 9:30 this morning. Please hold your questions until everyone clears the room. This presentation is being recorded. Established in 2002, the Curtis R. Holzgang Visiting Scholar Lectureship honors an exemplary role model in medical ethics. This morning, we're honored that Dr. Holzgang is joining us for this talk. The Visiting Scholar Lectureship is a program of the Center for Healthcare Ethics named for Dr. Holzgang, emeritus faculty in the Internal Medicine Residency Program here at St. Vincent Medical Center. During his tenure as Director of Critical Care Medicine, Dr. Holzgang was an inspiration in ethics education, especially for internal medicine residents and nurses working in critical care. It is now my pleasure to introduce Dr. Mark Kashevsky, our speaker this morning. Dr. Kashevsky is the Father Michael I. English Professor of Medical Ethics and the Director of the Neiswanger Institute for Bioethics and Health Policy at Loyola University Stritch School of Medicine, and past President of the American Society for Bioethics and Humanities. Dr. Kashevsky is a dedicated bioethics educator and is known for having created 2 of the major online graduate programs in bioethics. Dr. Kashevsky's current interests include attention to the role of culture and spirituality in decision-making. He has been an articulate spokesperson for the just and equitable treatment of immigrant patients and health professionals. Dr. Kashevsky served as the project manager of the Loyola University Chicago Stritch School of Medicine effort to include Dreamers in medical education. This resulted in Stritch becoming the first medical school in the nation to welcome applicants from Dreamers of DACA status. He is also co-chair of the university-wide Dreamer Committee at Loyola University Chicago that seeks to foster inclusion of Dreamers in all aspects of life of the university, including its research, education, and service missions. In addition to his influential role at the university and his extensive research and scholarship, Dr. Kashevsky has received numerous awards, including the Moral Courage Award from Faith in Public Life, the Transformative Education Award from Loyola University Chicago's Department of Student Diversity and Multicultural Affairs, special recognition from the Illinois Legislative Latino Caucus Foundation, the Carmen Velasquez Warrior Award from Alivio Medical Center, the Policy Award from the Health and Medicine Policy Research Group, the Strangers No Longer Award from the Archdiocese of Chicago, and the Cultural Unity Award from Teach. And in 2017, he was named co-winner of the Loyola University Chicago Faculty Member of the Year. Some of you may recall that just 2 short years ago, Mark served as the keynote speaker for the 26th annual statewide Kinsman Bioethics Conference, co-hosted by our Ethics Center and the OHSU Center for Healthcare Ethics. Mark invited us to see beyond the traditional issues, questions, and frameworks of clinical ethics. He called us to get to work on justice concerns that can result in worsening the acute crises we sometimes see in the hospital and beyond. In asking Mark to give medical grand rounds today, we have encouraged him to treat this audience as familiar with and committed to the highest ideals of ethical healthcare practice in order to seriously confront the question of who is our neighbor at a political moment that can often feel altogether unneighborly. In this, for example, we seek to better understand the ethical components of the competency domain of systems-based practice. Let us now turn to that intersection of bioethics, social justice, and being healthcare professionals. Please join me in welcoming Mark Kashevsky.
Well, thank you for that kind introduction, Nick. And I want to start, though, by saying a few words of gratitude to Dr. Holzgang. It's really quite an honor to be a Holzgang visiting scholar. We had a little chance to chat before this session started. And really you have here a pioneer, a local hero, somebody who in the mid-1980s, when really the nation's thinking about end-of-life decision-making was at a crossroads, and people really didn't know how to think about that, about withdrawing a ventilator. Are we harming a patient, or is this something we should be doing? How do we bring to our tradition of care in the medical field to bear on this? It's somebody toughing it out right in the trenches there, and we're working with his team to try to figure that out and implement something that was worthy of the values of your tradition. And so it really is quite an honor to be lecturing in a series named after someone like that. And his support of this lectureship obviously helps bring resources to the system, and along with the Providence St. Vincent Medical Foundation, really deserves gratitude for the resources you have now. That it's so easy for all of us to take for granted now that we just have resources in bioethics like Nick and Kevin Dirksen that you can turn to on a daily basis to tough out these ethical issues. But we're standing on the shoulders of these giants like Dr. Holzgang and the foundation. So why don't we give him a nice hand? I'm here to talk to you a little bit about caring for immigrant patients, which is something that you do all the time, every day. You're in a diverse community. And as Nick mentioned, though, we are at a time when we are being challenged by the common thinking a little bit about this, and what our responsibilities are at this kind of moment, especially for a Catholic healthcare system, really come to the forefront. I'm a person who was a generalist in bioethics and had a fairly successful career, but would be asked to come speak at different places a few times a year, not too common. Since November of 2016, I am now a hot ticket. I'm going everywhere all the time because things have changed. There are new challenges, there are new ways of thinking, and people want to respond. And so that's what we're here to talk about. How is it that we can respond? And particularly coming from Loyola Chicago, a Jesuit Catholic institution, to the Providence medical system, to think a little bit about how we draw on the tradition and values we have. We don't have to all be Catholic to draw on those values, but those are the values that have been infused in our health systems. And they are a tremendous resource for us at a time like this when we're facing these challenges. The backdrop to all of this is what's going on in our country in terms of the image that people are really putting forward of immigrants. Negative images, right? Really, and unfortunately, September 11th, 2001 gave us this unfortunate image of what an immigrant might do to our country, and really gave people who want to play on our fears something to draw on, the image of an immigrant as a terrorist. And now, of course, more recently, we are hearing people who want to play to our fears, talking about immigrants as gang members, MS-13, as if we have something to fear. And once again, trying to separate and divide people along our fears. And we have, but of course we have this much older tradition in our country of Lady Liberty standing in the harbor of New York with her lamp, that called all of our families here at some point in the history of this country to come and be part of this nation, to work hard, to build the country, to meld into a melding pot in all our diversity. And really, that was what was considered to have made America special, was that kind of nation. And of course, you have an image here, which is a fairly contemporary issue of somebody coming across the border without authorization. And I think for a lot of people, that one's the Rorschach test. What do they see in that image? Do they see hardworking people coming here? Do they see people fleeing violence, injustice? Or do they see people coming here to try to take something from other people that they think they're not entitled to? And that's the kind of thing that we're challenged with. And of course, to many people, that is the image of who's coming here to the United States. But I'll talk a little bit about how that's not entirely accurate at this moment in our history. Some of our context As I said, this used to be a snoozer of a topic, but immigration is exciting now. And approximately 11 million people are here who are undocumented in the country. And those estimates vary a little bit. You hear numbers from about 8 million to 11 million, because of course, obviously, by virtue of being undocumented, we have to extrapolate from other data. And part of that is we don't know how many people actually left the country during our Great Recession in 2008. But, and interestingly, there was a study last week that was released from Yale. Some statisticians tried a different model of this and actually said they think there's 17 to 20 million undocumented people here, much higher number than anybody had. I'm personally skeptical that that's going to hold up on further analysis, but it's interesting for a variety of reasons to think about what if that's actually true. Most of those 11 million, over two-thirds of them have been here more than 10 years, which means they're a part of our community. They've been living here a while. This is home. They've been contributors to our communities. And they're coming into our hospitals and health systems. But again, as members of our community, not as strangers, as new arrivals, but not all that new necessarily. And of course, the problem for health systems is they are ineligible for virtually all benefits. And so resources have to be found in some way to help us care for this population. And we'll talk a little bit more about that in a moment. We do believe the undocumented population is less than it was before the Great Recession hit in 2007 because people don't just move for willy-nilly. They move for economic and social reasons. And so if you're going to starve here, people tend to starve closer to home, and they will go back to where they are. And so when there were no jobs here, many people left. And we don't know exactly how many. But because it's harder to get back into the country, because our immigration laws are so restrictive, many people who might have left probably didn't. In the old days, there was more of a flow back and forth across our borders, depending on where opportunity was. But people are reluctant to do that because they don't necessarily feel they can get back in. Until 1997, 1996-97, 3 laws were signed into effect by President Clinton, a Democrat, in conjunction with the Republican Congress, that made it much harder to adjust status if you came here without documentation. In most eras of this country's history, when our families came here, the distinction between legal and illegal, authorized and unauthorized, was a fairly thin distinction. Many people came here without proper authorization, but the difference was you used to be able to adjust your status over time. There were things you could do, like go across the Canadian border and come back in through Canada, and you could adjust your status. But in 1996-97, that all changed, hence creating this permanent class of people who are unauthorized or undocumented. And so to a large degree, we've created the problem of the undocumented through our laws. The right-wing libertarian Cato Institute tells us that undocumented immigrants and immigrants in general are generally very concerned with getting by, with working hard, with trying to get ahead, and so they commit crimes actually at much lower rates than the native-born population. When I mentioned that study last week from Yale about what if the undocumented population is actually twice what we currently think it is, that would mean that their crime rate is actually half of what we think it is. That's part of actually what makes me a little bit skeptical. I think immigrants are really great people. I don't think they're superhuman. But so I tend to think that maybe that weighs a little bit against the statistical modeling they were using. But nevertheless, their rates are lower rather than higher. They are not a threat typically. And of course, one of the interesting things about this is that we may be cutting off our nose to spite our face. We actually limit the contributions that undocumented people can make to our society by virtue of not letting them adjust their status. For instance, with the Affordable Care Act exchanges, buying individual policies on the exchanges, what do we know? We know that they suffer from a lack of young, healthy people buying policies, right? We need the young, healthy people buying policies to offset the older, sicker people who are buying policies on those exchanges. Immigrants in general are younger people. old people don't generally get up and move to another country. It's hard for older people. It's younger people who come to, who migrate typically. There's a lot of young, healthy, undocumented immigrants who could buy a policy on an Obamacare exchange if we just let them. And that would help offset some of this. So that's just one example of ways that we limit the ways that people can contribute. But they are contributors, typically paying taxes and all that, even though they can get no benefits. Some of the things I think we should think about from the Catholic tradition in this, when you know these facts about the crime rates among undocumented immigrants, what you realize is some people are just good old-fashioned bearing false witness against our neighbor, right? Anytime you say a falsehood about somebody that portrays them in a negative light and you know the facts are simply there to tell you that that's not true, that is bearing false witness. You're lying about your neighbor. And we need to call that out as individuals and as a church, as health systems, as institutions. And of course, the idea that somehow, everybody says, oh, my family came here appropriately or whatever, we're not the same as these. And you always hear this explanation that somehow this wave of immigrants are different from previous waves of immigrants. Not true. And so I think that looking at gospel passages where Jesus tells us to identify with the people who are marginalized or outcast is something we need to be thinking about in this. That they are us, we are them. There's not that much difference. Pope Francis, in his very first homily after he was in the Vatican, he took a trip to Lampedusa, an island in the Mediterranean, which is a famous destination point for immigrants or refugees trying to get across from North Africa. And many people died there. Their boats capsized sometimes in the waters and things like that. And he actually talked about the globalization of indifference. The idea that we hear this in the news so often that we have trouble getting outraged or even mustering a response to it. And he said to us, has any of us wept because of this situation and others like it? And so we have to actually, and in the United States, fortunately, in this year, we are starting to muster a little bit of outrage as we see families broken apart at the border, children separated from their parents. We did see some outpouring of outrage, and we have to fight because it becomes commonplace to become indifferent to that. And that's what our tradition calls us to move beyond that. And for that indifference, Pope Francis actually ended his homily by saying, "Forgive us, Lord," because at those moments when we are indifferent, we are in need of forgiveness. It's not just others, but ourselves as well. Something I should add to this, the average immigrant, the undocumented immigrant to the United States right now is actually Asian and not Latino anymore. And that's partly because most immigrants to the United States now are coming from Asia and not Latin America. While we still have some people coming from, a lot of people coming from Central America, many more people are coming from Southeast Asia, India, Pakistan, China. And so and that's again part of this false witness thing. The idea of building a wall on our southern border to stop undocumented or unauthorized immigration. I can tell you, if most of them are coming from Asia, that wall isn't going to do a thing, right? And so it's important that we actually call out all of these kinds of falsehoods. And one of the things that we hear is that a lot of times people accuse us of being Democrats, and that's why we're talking about this stuff. It is not politically motivated. This is old in the Catholic tradition. It didn't start with Pope Francis. Think about in the year 2000, because remember I told you in 1996-97 we made our laws a lot harsher. The U.S. Catholic bishops started calling that out fairly early on. To say that, and actually asking for those laws to be repealed without any luck. But they pointed out that the problems with those laws is that if you're here for more than 1 year without documentation, you have to leave the country, and it's 10 years before you can even apply to come back into the United States. And so by making laws that harsh, again, we've sort of we're keeping people in. There's no incentive to try to adjust status or go out of the country and come back in. because of the fact that the laws really are prohibitive for this. Eliminated virtually all benefits. A few of them got restored, and you may be aware that the federal government is now floating some proposals to change the few that have even been restored, such so that keep preventing pregnant women from using Medicaid or things like that for lawful immigrants. And so there were, so the laws that were made harsher in 96, 97, there are proposals to make them even worse now, and we have to fight that as systems. John Paul II, again, not considered a liberal pope, right? He's St. John Paul II, was very strong on this issue. And the thing that he pointed out really was that we are creating the problem of the undocumented migrant. That we react by tightening our laws, and so suddenly we have a large undocumented population. If the laws were more in keeping with social and economic realities, we would not have undocumented immigrants. We would have people assimilating into our society. And it really is just that we're divorcing our law from lived realities. We're living in la-la land and creating that rather than taking into account those social and economic realities. During the 90s, what was happening? The flow of capital was being made easier across borders. The North American Free Trade Agreement, other trade agreements. And so that was a good thing. Jobs were being created, but many people were being displaced. Much of our agricultural investment in Mexico displaced people off the land. It made the land much more productive because we brought modern techniques there. But those people moved north towards the border to work in the factories that were being created along the border, at the northern border of Mexico. It seemed like a great thing for everybody. But then, of course, economics changed. Those factories moved to Asia. Where do those people go who are working in the factories? They can't go back to the farmland. They come across the border, young people to an aging society to work in the service sectors. And instead, we make it hard for them to adjust. So we create it by not taking into account those realities. And so John Paul II tells us that we have to keep that economic and social dimension of migration in our minds. And he further told us that there is a natural right of individual persons to move freely within their own nation, right? Nobody questioned me from coming from Chicago to Oregon, right? From Illinois to Oregon, we can move freely within our nations. But there is a right to move from one nation to another as well. And that's not an unfettered right. It isn't necessarily that a nation can't control its borders. But it is that a nation has to justify why it is excluding people who want to come in. Why, when people are coming in saying, we want to come and work hard and assimilate and contribute to your society because we're in danger for our lives where we're coming from, we are starving where we're coming from, our children need a future. You need to, the burden is on you to explain why it is you are keeping them out. And so it reverses the presupposition. It's not that people have to show their merit to come in, but you have to explain why what is it, the situation in your nation that prevents you from taking them in. And so it's simply a matter of the worth of human life that we have such a right. And Pope Francis, in a recent publication, put forward something which to many of us seemed like common sense, but has really created quite an outcry from some sectors of the church. He really said to us, you know, we are a respect for life church. We are a pro-life church. We think of the dignity. Dignity literally means the worth. That's a Latin word for worth, the worth of all human life. And yet we have emphasized some things, some bioethical issues like abortion and contraception, as if they're the only things. And yet these other things like trying to migrate to feed your children is also a life issue. And it belongs on that same paramount level of attention that we give to those other issues. And so he really called us to look at these issues as if there's something that belongs in our tradition right at the top level. And hence, that at a Catholic institution like this, we find ourselves talking about this as well as those bioethical issues. What do I think follows from all of this? I think there's a basic view of human nature that's behind the Catholic thing. And really it is that Catholics believe that people are laboring animals. And really this is straight out of John Paul II, that our work is part of who we are, right? First thing we ask each other, what do you do? Where are you from, right? And those are the questions we ask. Because our labor helps define us. That's our contribution to our community. And we're people who want to contribute to our community, right? It's hard for us when we retire or if we get a disability and we can't labor in the community in ways that we were considered productive, right? Because that's part of our nature. We want to contribute to that community. We're makers. We are co-creators along with God. And so to think of people as people who want to come and just take is automatically to reverse that presupposition of our Catholic philosophical anthropology. And of course, we're familial animals. We want to be with our families. We like our extended families. That's part of how we express ourselves as well, and also our co-creation of a community. And so that means that because of that connectedness, that tendency to want to be in a work environment, to be near our families, we are reluctant migrants by nature. We do migrate, but we don't do it easily. We don't just pick up and relocate our lives easily. And because of that reluctance, we have to then ask why, if somebody is actually taking that step, why is it you're turning them away from your community? Because they have that natural right to try to thrive, just like all of us do. And that's the Catholic view of human nature. And as a result, I think if some policies follow from that, that there should be periodic adjustment. When people have come and contributed to your community, when they've contributed through their labor, through their taxes, through raising their families in your community, become connected to that community, there should be some pathway to become a full member of that community, not just always left in the shadows, always left in fear, always marginalized. Family reunification. Right now you're hearing a lot about switching our system of immigration from a family-based system to a merit-based system. How much education and how much money are you bringing, and we'll let you in. If you're coming with your family, you're coming because your parent is here, or you're bringing a child here, no priority for you anymore. And that's the kind of proposals being floated. But we believe in the idea we're family animals, and that system that preference for family should remain in place. Similarly, for young people, we hear about the DREAM Act occasionally, which is to give lawful status, a path to citizenship to young people who have been here, were brought here as children and have grown up here in our communities. And that's been held up many times. It's been in our legislatures since 2001. And clearly, young people who know this is the only home they know should get a path to citizenship. But my belief is that the Catholic teaching suggests that it shouldn't be a one-time thing. We're just going to legalize this group of young people who are here. It seems like it will always be right that if somebody has grown up here and this is their home, when they become an adult, they should have an opportunity to file for adjustment of status. When will it ever be right to take somebody who was brought here at 5, grew up here, knows this is their only home, and say, you can't stay here, you need to leave the country? And of course, we need to decouple our thinking about health and health care, education, public safety from immigration status. It doesn't serve any of us well to tie any of that to immigration status, right? You hear this term sanctuary cities. The idea that people should be able to call the police no matter what their immigration status, because that keeps us all safer. If they see a crime, they need to be able to report it. They can't be in fear that the policeman is going to take them in and deport them. Same with healthcare. People need to be able to come in and get healthcare. They need to be able to buy insurance. They need to be able to qualify for benefits the same way everybody is. Otherwise, we get these problems where we don't know how to finance the delivery of care to people. So what kinds of things have arisen because of this? And again, this problem's been going on for a long time. I sometimes say there's first generation issues that have arisen. And those really come down to things that we see where, say, a young migrant, as I say, most of the time they're young, working in construction, gets a rather severe workplace injury, comes into our hospital. We stabilize the person, but they need long-term care or rehabilitation care because the injury isn't going to abate just in a short time, but they need to be able to get back into the workforce. And unfortunately, they get stuck in our hospitals because normally the safety net thing like Medicaid, which would pay for longer term or rehab care, they're not eligible for. And so we end up with the person stuck in the hospital. Dialysis, right? Ongoing chronic needs. that become a cost to the system because they can't qualify for Medicaid and other ways that people normally benefit. And again, you see how inefficient it becomes. They'll come into our ER. We have to dialyze them emergently by EMTALA. We discharge them. Well, their renal function isn't going to be healed. They're going to need dialysis in a few days again. Then they come back into the ER after they can't wait any longer. And so having a safety net system would be better, where we can put them in a dialysis clinic and get them regular dialysis. And similarly, organ transplantation. Undocumented people do contribute to the organ system. They donate organs at a pretty good rate after they pass away, but they cannot benefit from it. So that dialysis patient often can't get a kidney transplant, largely because they can't qualify for the anti-rejection medication funding afterward. And so it becomes a chronic problem. And so then the issue of that first generation was, how do we discharge these patients, right? What's the way we're going to do it? And so with first generation issues, I always say, the administrators always start by saying, the first thing they say to you is, we can't do everything. And they're right, we can't do everything, right? The hospital can't fix the whole social system. But I always say, that doesn't mean we can't do something. And that's the part we have to figure out, is what it is we can do. Because basically our values are a problem. We're caring institutions, right? It hurts us to turn people away and say, we can't help you. So we have to somehow make that value come to bear on this. And we like efficiency, right? We don't like the idea of keep dialyzing the person who's showing up at the ER. That's not efficient. That's going to make them sicker. They're going to wait longer till they show up. They're going to have a lot of sequelae from not getting it on a regular basis. We'd rather deliver that care efficiently. And we're concerned about the public health, that people aren't coming in for treatable diseases that may be communicable. We're going to have a problem in the community. So in our solidarity with our community members, we want to create a system that is efficient and caring. And so very typically, we try to work out some compromises. What are the criteria? How long does somebody have to be waiting on our dialysis list to get a slot? How many slots can we allocate to this? If we're contracting with a dialysis company, let's sit down at the next contract negotiation and say, how about we split the cost for X number of slots? We try to find a way that we can find a way to treat a number of people that at least makes us feel like we're taking some share of the load here. We can't become necessarily the magnet for everybody. You've got lots of competitors in town. You don't want their plant to all give a bus ticket to Providence Health, right? But you want to weigh on their conscience and say, what's a fair share here? And how do we find that fair share? How do we help our patients? And how do we define who is our patient in our community? So what is that something we can do? We are now in the second generation of ethical issues related to undocumented migrants. The first generation was, how do we discharge this patient? The second generation question is, how do we get that patient to come back in? Because of the fear in the community, people are trying not to go into public spaces, partially just from fear of actually going outside in some communities, but also partially because you look like a public institution in some way to them. You look pretty public, and what your relationship to the government isn't always clear to your patients. And so they're kind of afraid necessarily to be in records, to have things, have you perhaps know about their status or suspect their status, and they don't know what happens if an ICE agent comes into your facility. And so we are seeing drop-offs of these patients coming in for care. And so we're having more people ask us as ethicists, what do we do? How do we get them to come back? And of course, it's again an organizational question. The same values are at play here, right? We are caring institutions, and we want to be efficient. We don't want them waiting till they're deathly ill to come in. We want them to come in like they always did. And so we want to care for the public health. So some things that we do, some answers to that, to these second generation issues. Many hospitals, virtually all hospitals, I think at this point, but the vast majority have front door policies in which we know what to do now if an ICE agent shows up at the front door. And that often involves a designated person in our system who gets called by the person at the front door, asks that ICE agent to remain in place, not to go wandering around the hospital. And then that person from our facility comes and says, do you have a judicial warrant? We're not discharging any information or answering any questions without a judicial warrant from a judge. And since ICE almost never uses judicial warrants, that often stops things at that point. And mind you, it's just an extension of what we do typically under HIPAA for patients of all sorts, right? When the police come and ask, we're more inclined to help them, but still there are rules about when we're supposed to let out patient information. And those should involve a warrant and somebody asking when they're asking for private information. Of course, the problem with this is you're prepping for an unusual event. ICE agents don't show up at our doors too much. If you're not at the Texas border, where they're a little bit more used to this, most of us don't see this. So it's kind of like active shooter drills. You have to prepare for an event that may not happen or that may happen very infrequently, but you really want to get it right when it does happen, right? So you have to practice and you have to refresh and you have to get buy-in from the right people to be willing to go over and drill these things. And then, of course, we want our signage to reflect this under our non-discrimination policies, sexual orientation, gender, race, and immigration status. We want to say we don't discriminate under any of those. And of course, if we can develop one-on-one clinical interventions, all the better. And so one of the things, if you take nothing away from this talk, take away this URL, luc.edu/sanctuarydoctor. LUC for Loyola University Chicago.edu/sanctuarydoctor. It's a web page of resources for how to talk to one's undocumented patients about keeping them safe and about the stresses they may be under in the current environment. It was put together with myself and one of our medical students who graduated, who's now a resident, Johanna Mejias Beck, who, congratulations to Johanna, is now a US citizen, but was undocumented for most of her life. And so we have a frontline perspective on this. We've added a family physician, Dr. Amy Blair, to it. And what the Sanctuary Doctoring Program tells us on that website is we want to do 4 things. We want to open a dialogue with the patient about their situation. We want to reassure them about their situation, let them know that we are here to support them, provide them with some resources, because we can't do everything, but we can, in a 20-minute conversation, get them hooked up with some resources, and then begin to develop an emergency plan with them. And so inside of 10 minutes, we think we can do this. The web page has templates for a beautiful brochure that you can adjust to your own situation. We have no copyrights. Download it, adjust it to your situation, and beautiful buttons that you can actually wear that say, "Immigration Worries, Talk to Me," English or Spanish. And so you can wear that. It's based on the idea of public health campaigns for domestic violence. It was hard to get women to talk to us about domestic violence. But if you said, "Talk to me about domestic violence," in a big button, many would. And so try to make it easy for them to bring it up. There's the cover of the brochure template. And it tells them why we want to talk to them about this. Those problems can impact their health. You can talk to your doctor about this. And notice at the bottom here it tells us that if you'd like to talk to your doctor about this, and this is a template that was filled in for our Access to Care clinic, which is a safety net clinic we run at Loyola. Just hand this brochure to your doctor or any member of the staff. The patient's afraid. The patient doesn't want to talk about this. We want to make this as easy as possible. They just hand you something and it tells you if the ball's in your court, they want to talk to you about this. So opening that dialogue, it may be based on the handing you the brochure or pointing to your button. And then you want to make sure to tell them, make this seem normal. Tell them that many patients are experiencing these kinds of things because they feel like it's their problem. They've done something wrong. They're alone. Tell them they're not alone. Tell them that that many people are doing this. And you can even let them talk about people in their family. They may be asking for somebody in their family, but they may not want to say it's them. But if they want to say it's their family members, they can talk that way. The most important thing, assure them of confidentiality. Tell them you will not write their immigration status in the chart, because that's what they're really afraid of, that you'll put that in the chart and that will somehow lead to their demise. But tell them that they're safe to express their concerns, because you won't do that. But again, keep telling them this is really normal, that a lot of people are dealing with this. There's some of the inside of the brochure. It tells them a little bit about the pledge that you want to take. And again, you can modify this so that it fits your situation in your clinic. And that you want to listen to their problems, you want to find ways to reduce their stress, you won't record their status, and that you want to refer them to resources. particularly for their young people, for undocumented youth. We want to get them in touch with resources because their situation is changing. You may know that DACA, the program that's been protecting them since President Obama created in 2012, is now on the rocks. It's been rescinded, but a court order has kept it open for renewals presently. But that situation is very fluid as it goes through the courts. And young people need to know that situation because it changed within the last year. It was rescinded, but then having a judge in January say it was open for renewals, a lot of young people had to get the word to them that that's the case and that they could renew and it'd be good. Their work permit would be good for 2 more years. They need to be networked to know those kinds of things as they're happening. So we want to get information to them. And the brochure also contains various kinds of legal resources. I mean, you can see what happens. In the brochure and the template, you can borrow all the national resources, but then you want to add your local educational resources. If your local universities have diversity officers who are up on things going on with young people, with DACA recipients or dreamers, you want to add those to that, just like we did in Chicago. And of course, the young people feel pretty isolated, so getting them networked is pretty important. Telling them that you recommend Know Your Rights training, that can save them. Because the same rule, they don't have to open their front door at home to ICE. ICE has to have a judicial warrant to come in. But ICE is clever. They won't bring a judicial warrant. They'll try to intimidate their way in. People need to know their rights to not open that door. It can end up keeping a family together. ICE will walk up to a door and put a picture of a young African-American man against their window and say, we're looking for this guy. We're looking for him. We saw him run into your house. Let us in. And unless they realize they don't have to open that door, they're being fooled. They're being lied to. That they will open that door and it can separate a family. So telling them about Know Your Rights training, that they should get some, that's, of course, recommending that to them is one thing. You may at some point wish to hold sessions from qualified providers Know Your Rights training in your clinic so that they don't have to go somewhere where it's clearly for undocumented people. They're just walking into a clinic. But mostly tell them that they need to get some. But the one thing you can tell them is update their emergency contacts at their child's school. Make sure they're up to date who picks up that child if the worst happens. You don't want their child going into the youth and family services, into foster care. Who's the family member? Who's the close friend who's authorized to pick up your child? Now that sounds terrifying to talk to a parent about what happens if you're detained. Nevertheless, they're already thinking about it. They're already afraid. You're empowering them to do something about it. They don't have to just be sheer victims of this, and that's what you're providing by being that supporting voice. The same way you learn to talk about end-of-life decisions, you can learn to talk about these emergencies as well. And in the legal resources section of the brochure, they can just go online to get Know Your Rights training. If they're afraid to go out into a public place to get it, the ACLU has it online. There are other legal organizations that have it online, both in English and Spanish and various other languages. They can get that training. But then you want to add, if there's local attorney services, people who work on a sliding scale, work on pro bono kinds of things, you want to put them in your brochure as well for them. And again, there's the URL for this. And I could talk more about DACA and so on, but I'll stop there and take questions because we're at about 45 minutes into this. I want to make sure that if anybody has questions, or if you have stories, if you have things that you want to share, success stories or horror stories, anything, we want to hear it. Share it with the community, okay?
I just got a question about this. What do you do about translation of other language and reading level for those documents? Those look pretty written at a high level.
Yeah, good question. Language, the question is, what about language and what about reading level? And we have done these brochures in English and Spanish for our local community. Obviously, you might want to get it translated for any particular ethnic communities you have here as well. Reading level, we were at too high a reading level, and a local person, Lorena Sprager, came to us and said she could bring it down to a 6th grade reading level for us. And so we used her consulting services to bring it down to a 6th grade level. But those are the kinds of things that, without a lot of resources, it's hard to keep up with, but we're trying to do what we can with that. Other questions or thoughts you'd like to share? Yes?
I've been a physician on staff here for 40 years, and I just returned from Hermiston and Kennewick
I started a pediatric program in Hermiston that the Washington Health Alliance picked up and put into the whole state of Washington. And I have had an incredible experience with the immigrant population. One of my first patients said, in contradiction to what you said, in terms of documentation, is he says, every immigrant in this country needs to go to the Social Security immigration, sign up, and then come back regularly, look and see what their status is. If they don't do that, they are in violation of the law. And I had patients, for example, who were in this country 30 years, to DACA so-called, and they came here, they never paid taxes. They're criminal. And so that's the problem. And many of the patients I had who work in Social Security services and so forth for the Mexican Americans rail against the illegal immigrants who take advantage of the system. Secondly, the pediatric clinic in Longmont just went belly up because the Affordable Care Act does not pay for their care for the children. And in Prosser, a long-time pediatric clinic also went belly up earlier this year because the Affordable Care Act just dropped the price in half. And I ran a sleep clinic, probably saw about 4,000 new patients in 4 years, and they shut the prices down by 50% in January of 2015, and they cut the prices again 50% in July. So part of the problem is the government is not paying for the care of these people. And the pediatric patients, the doctors, they're all upset because they come in there, they get their $150,000 cut in what they owe on their insurance and their health care costs for going to medical school, and then they get out. They want to get out of town. They're not happy. So, I mean, there are huge problems within the system. I had a wonderful opportunity to see it.
Yeah, thank you. Yeah, there are definitely huge problems within this system. There's only about 4 states in the United States whose S-chip program has been adjusted to deal with undocumented youth. And clearly, I think the least controversial of all proposals is that people under the age of 18 should be able to get medical care. And so the idea that S-chip programs should be expanded across the nation to take care of that would seem appropriate. Though in reference to the issue of everybody signing up for with the Social Security system, there, as I mentioned, many undocumented people do pay taxes through getting taxpayer ID numbers rather than Social Security numbers, which they're not eligible for, and do file as individual businesses essentially and pay taxes through that. And immigrants tend to be highly entrepreneurial and start businesses at high rates, being job creators. And so it doesn't make a lot of sense to keep them outside of the system and only in that tax-paying ID system. Now, but again, for most of the undocumented population, there is no way to adjust their status. And so they're trying to do whatever options are available to them, either by working off the books or by paying taxes as an individual business. And so I do think that anything that we should do with immigration reforms to rectify that situation would be to the benefit of all of us. Other questions, thoughts? Yes, sir.
Can I ask you about the practical issue of promising not to list immigration status in any medical record? I'm having a little trouble wrapping my head around how we can meet the needs of a patient in a big system if we can't document who they are.
Yeah, and that's actually the biggest issue we're facing, I think. Thank you for that question. I think that's important, because yes, continuity from one visit to another is extremely important, and those needs are often spread over time. And so now, mind you, very few people have been writing in the chart up to this point any immigration status. It's not something we typically have been writing in it. But so things like writing ineligible for Medicaid is some ways you can convey what the situation is, so you don't have to ask each time, can we fill you out a Medicaid application, right? But you want to keep it focused on the particular need that you need to address from one visit to another, rather than put the blanket statement about immigration status in the chart, because once you do that, you set off bells and whistles. And truthfully, I don't know how realistic the fear is, but down in Texas and along the border, some of the cases where ICE has come into hospitals and put pressure on are often thought to have been whistleblower situations where some healthcare worker got wind of a patient being undocumented and called the federal authorities and so invited into the health system situations they didn't want. And so that's the kind of thing we're trying to avoid by really focusing on the particular problems. But it's tough. And some healthcare providers tell me that they, in particular clinics, they've worked out certain billing codes or diagnostic codes that they use that give them a signal this is undocumented. We can't advocate for anything like that nationally. It would be the same as writing undocumented in the chart, right, if everybody's using the same code for it. But there may be local systems that can be created. Dr. Castañares?
Thank you. I know in your professional writing you've talked about medical repatriation.
Thanks. In your professional articles, you've spoken of medical repatriation. I wonder if you could tell us what that is and where you see it now.
Yeah, thank you for that question. Medical repatriation is when the hospital actually medically transports a patient back to their country of origin. And the situation can be forced or it can be voluntary or semi-voluntary. I wrote an article about this in which I talked about what I think are best practices in this situation and really argue pretty strongly against any kind of forced medical repatriation, against the patient's consent to be arranging their transport back to a country of origin. And I argue on that for a few reasons, part of which being that no immigrant patient is ever going to come back into our facility if the word gets out that we are really an arm of ICE. We will deport you medically. And of course, it was done for those cases where, again, the kind of injury where we can't discharge a patient. And so I really think we have to find other ways, such as sometimes with the health systems using charity dollars to send that patient to rehabilitation and pay for the rehab on our own. But we also want to be careful that we don't overdo it and never enable a patient to consent to a transport that is in their best interest. We had a tragic situation at Loyola where, trying to be very sensitive to this issue, we had a patient who was dying from a terminal illness, and the patient was here, their family was in Mexico, and people were saying, well, should we try to send them back? And he was like, nope, we're not doing it. We're not doing medical repatriation here. He ended up dying in our hospital, and afterwards we kind of reflected and I said, well, wait, he came up here to work. His family wasn't here. He couldn't work anymore because of his illness here, and he ended up dying alone rather than with being surrounded by his family. And so shouldn't we have really said to ourselves, what does the family want? Would a reasonable person say that's in his best interest regardless of the finances? And if that's the case, maybe we should get one of these medical transport companies and try to send the patient back. And so it can be compassionate if we partner with patients and families, but we don't want to see our policy of dealing with the financial aspects as deporting people or giving them bus tickets to other states. That's, I really think that will defeat what we're trying to do as a healthcare institution. Yes, sir.
Is there any data, either nationally or state-wise, as to how many human beings, because of their medical event, have been picked up by ICE?
Yeah, I haven't heard any studies.
Is it hundreds, thousands?
Yeah, and it's really hard to venture a guess, but it's probably not thousands. I suspect it's lower than that. ICE tends to, now in the Obama administration, there was a guidance document issued that they were to try to avoid hospitals, schools, and churches. And so ICE was not to do that. And that guidance document, of course, has been rescinded since then. So as the president once put it, the shackles are off ICE, and which is a really interesting metaphor. But even so, they understand the public's sensitivity to coming into healthcare facilities. They know the public doesn't like that. So there's more reports of intimidation, drive-by, walking into facilities, not actually trying to apprehend anybody, and of checkpoints being set up between facilities. And so again, in places fairly close to the border where they know there's a high prevalence of people who are undocumented, to put a checkpoint between the little community hospital and the tertiary care facility and try to get people on the road as they're going from one to the other. And so, it's more that kind of thing. But yeah, this probably isn't in the thousands. Probably what we're really dealing with is more health consequences from the fear of it than from the actual reality. And so that's to a large degree what we're trying to do. We sometimes call the Sanctuary Doctor program treating fear, because it's the fear more than the reality that's really crippling people right now.
Are there states or places that are particularly good or bad at that connection? Is that sort of under the radar known data, or not known data, but known places, good and bad?
Yeah, and I don't really have a good answer to that. And again, things are changing fast. Suddenly last week, Madison, Wisconsin became a hotbed of trying to pick up undocumented immigrants. And I don't normally think of Wisconsin as a place where you'd really be living in fear from this, but Dane County, where Madison is, there's a lot of undocumented farm workers. And so where you're safe and where you're not can change from day to day. Yes, sir.
When you're talking about undocumented immigrants, not only Asians, but particularly Mexican Americans in this part of the world, are you talking about poor people, or are you talking about people who are financially solvent? Which is the population most characterized by?
At this point, right, like most immigrants, they're on the lower economic rung of the ladder because they're trying to work their way up.
Okay, so in 2016, National Public Radio announced that the Mexican Americans purchased 20% of the population, purchased 55% of the new homes in America, and 85% of the new businesses in America were Mexican American.
Mm-hmm.
They're a cannonball, and where I came from in Eastern Oregon, the gringos virtually can't get a job because they are looked upon as coming to work with their cell phone, you know, and the joke is you can run over a Mexican with a forklift and they'll get up and go back to work. A gringo gets a hangnail and they gotta go home.
Right. Yeah, well, you know, as I say, immigrants tend to be hardworking. They tend to be entrepreneurial. Tends to be fairly small businesses. And of course, some of the limits placed on it are by ability to gain certain resources and certain statuses. I would just say about the Asian thing, you know, for a while, Mexican Americans were more than half the undocumented population of the US. It is now much less than that. And so it is the Asian population is growing. They are under the radar and they are quieter, they're less advocacy focused. But it is I would say probably in your community, that's the population that's growing here right now.
Probably have time for one more question.
You've spoken of dialysis as one example of a challenge to our hospitals and health systems for uninsured people, and I'd say uninsured people in general for whatever reason. I wonder if you could comment on any successes you've seen with other kinds of high-cost care like cancer outpatient treatment or organic brain syndrome and long-term care, if you've seen any creative solutions to how that can get paid for people in need.
Yeah, and you know, and unfortunately, I'm going to have to punt on that. I haven't, you know, but I haven't been focused on that largely because I've been looking at the most common issues related to the community. But more of this is going to happen because part of what we're seeing is, again, by now we should have had immigration reform. We should be on our second round of immigration reform. We should have had probably some 15 years ago. This population came here young. They're growing older now, right? Because the longer you stay, eventually you get to middle age and you start to get all the things that middle-aged people and older start to get. And so we're going to face those questions more and more. And I haven't yet really heard a lot about that, but that's the future that we can work on together.
Please join me in thanking Dr. Kashevsky. So thank you again for a great talk. We will have Q&A now for 30 minutes, so if you aren't able to stay with us, please feel free to exit. Hold your questions, and we'll regroup in about a minute. Yeah, right. Okay. Oops. Do we have a question? Yes. Oh, this one? Sure.
I just had a question. You say a lot of people who are undocumented don't want to go to a clinic or to a hospital. Do you have programs where doctors can do in-home visits? Is there any program like that?
Yeah, well, that's a good question. What do you know, Tina?
Well, sort of. You know, what I've heard about involves federally qualified health centers, largely.
I think these two things might be related to your question that we've seen here in Oregon. Federally qualified health centers, which is a national thing, and they are, by the way, not allowed to ask about immigration status. So that's helpful. And their knowledge of their unauthorized immigrant population is done by proxy, like people who aren't eligible for Medicaid when enrollment is offered. But that's helpful, and some of them have home visiting programs for any patients, not necessarily singling out unauthorized immigrants. The other is the community health worker movement, promotores de salud for Latino patients and other ethnic groups and targeted populations like the disabled. Community health workers being lay people who often are in the home, and that can be a terrific liaison referral base for needed health care and even sometimes a provision of health care in the home setting. So, but it is important, I think, to know that the folks that you're talking about today, they're not eligible for Medicare home health, they're not eligible for Medicare hospice benefit or any of that. So the home care workers we think of in our insured systems, really they're not eligible to get. So we have to get creative with other ways to see them in the home. It's a great question, I think.
Yeah.
Hi. My question may be kind of odd. I'm kind of interested in the context of this whole thing because we've heard about it so much in the last few years. And I remember 30 years ago hearing about, you know, the cultural changes or the ethnic changes in our country just from reproduction. And if you look back in history, this country and probably other countries have had a huge "we don't like immigrants" thing. I remember I was reading some history from the 1700s, early 1800s, and it just repeats. It's economic, it's we don't want them taking our jobs. It's all this stuff that isn't really true. And to me, it ties into diversity. And our organization has an effort to try to be inclusive and support diversity. And so a lot of people in this part of the state anyway have that understanding. But this seems bigger. I mean, we have a long history of doing the same thing, just in different ways. Either it's just it migrated up to real strict rules. I mean, is that right? What I'm thinking?
Yeah, I know, and that's exactly right. When I talk to reporters about this, and they say, "Are you guys just interested in this because you're a Jesuit Catholic institution?" And I always say, "No, that makes us more sensitive to it." But they're things that everybody should be able to relate to. We're sensitive to it because the last great wave of immigration, the signs went up, "No Irish need apply," right? No Catholics, no Poles. And so we were discriminated against. And so our institutions were often founded for the group that other people wouldn't take. Our universities were founded and colleges for the students that couldn't get into the white Anglo-Saxon Protestant schools. And so it's a recommitment to our heritage in many ways to be taking this up. And so, yeah, it's very much the same as it's always been. And it's unfortunate that people forget that history. But it's a recommitment to our roots, which is a beautiful thing in many ways. When I think about walking the Loyalist Health System, which is a Trinity hospital now, there's a lot of doctors there named Fahey and O'Brien and names that you don't see in such large quantities elsewhere, right? And it's why? Because their families raised them thinking these institutions were for us, they're our places, and we support them, and it's a privilege to work there. And we are hoping that the next generation of people in those facilities are named Ramirez and Wong, and they're saying, when nobody else was taking us, this place said, welcome. And that's been our effort with you heard in my introduction a little bit about our DACA students at the Stritch School of Medicine, being the first medical school in the country to say, you can apply and compete for a spot on a level playing field at the Stritch School of Medicine if you have DACA. And we will commit to trying to find you financial aid, because again, they can't get federal student loans, right? And we've been fairly successful. We have excess of 30 such students. We just graduated our first class. We have 6 in residency right now. Yeah, applaud. Yeah. And I'll tell you what that did for everybody's spirits when they went on to residency. There will be we will have about 8 in the match this year. There are 20, we think, around the country or so in the match, and we're hoping residency program directors, despite the uncertainty hanging over DACA, will take them in. Because when we talk about, we get used to buzzwords like diversity. But inclusion, when you include somebody, you make them their own advocate. It shouldn't be us necessarily doing the advocating for other people. Those students in their white coats are out there in the Washington Post and in Huffington Post telling them, we grew up watching people who couldn't see a doctor. There's Emmy Garcia there. She says, she grew up in a mixed status family. She didn't understand why her brothers and sisters could go to the pediatrician, and she never was able to go to the pediatrician no matter how sick she was. And she says, I want to be the pediatrician for kids who have no pediatrician. And they're able to tell that story nationally, to advocate for themselves. They are constituents now of the AAMC and the AMA who are advocating for them in Washington. And we don't have to necessarily be the advocate. They can be it for themselves. There they are dining with Senators Durbin and Duckworth from the state of Illinois after addressing the Democratic Senatorial Caucus to explain what the need for legislative reform. They can go advocate for themselves. That's the real dignity of a human being. You're recognizing their ability to, it's the old give a person a fish, feed him for a day, right? They are fishing right now. They're changing that image. That first slide I had, now the image of the undocumented immigrant might be of your doctor, right? And so it's, this is what we're doing. It's all as you're saying. Kevin?
Mark, thank you. Thanks. I'll play by the rules too. I wanted to do a play on a little bit of your slides about first generation ethics issues in this area and second generation. And the paradigm for which you discuss some of the second generation issues still seems to be the sort of healthcare of somebody who walks in the brick and mortar of our healthcare system, as opposed to some of the thoughts that we're having about population health, which I define as a population for which a health system has some degree of obligation for, some accountability for, but also community health, and what is our community and what are we responsible for in promoting the community's health. Can you comment on sort of that aspect of this discussion? How does this impact our sort of increasing conversation in some health systems to become population health or community health companies? And what opportunities, what challenges?
Sure. Yeah, no, that's a great question. And Dr. Castagnate sort of touched on this when she talked about the promotores de salud, right? The having health workers from the community, in the community, working with people. And you're right that many health systems who've rolled out their health plan really will take in the undocumented along with the documented just because they want large numbers, and better just to get everybody healthy rather than leave a population out there that's not going to be healthy and so on. So yeah, so managing this population upstream, the potential is enormous, right? Because I mean, the biggest problem that most of this community faces is nutrition, right? When undocumented people come here, or when any immigrants come here, forget undocumented, immigrants come to the United States, they tend to be pretty robust and healthy and young. And then they get here and our food kills them. It's really, American food is processed, comes out of cellophane, has high in fats, high in preservatives, high in additives, sugars, all of these things, right? And so suddenly you see, as people are here longer, what happens to their health curve. And so there's a lot of fairly simple things, but that are hard to change because that doesn't have cultural roots to change those eating habits here yet. And so, but yet that kind of partnership with the community to work on things like preventive care, nutrition, all of those kinds of things. But it is going to take efforts to go into the community and be of the community, empower them in the same way we've empowered medical students. Find people in those communities who can work with them. Find culturally competent physicians who can go into those communities. But the upside is enormous if we can harness that energy. But it does take a shift from try to keep them out of here because we can't solve the whole problem to let's just do it. Because if we do it well, we can actually make this profitable.
I'd just like to ask you about one of the moral and ethical, as long as you have that slide up there, moral and ethical failures of our society is to make DACA legal. And I want you to comment because during the previous 8 years of the Obama administration, you had a Democratic president, Democratic House, Democratic Senate. Those people that you're talking about sitting there voted against DACA. I'm asking you, what can be done? What is the problem with this Congress that they won't do it? Under Trump, Trump wanted DACA. In fact, he increased the number of people from 600,000 to 1,800,000 that he thought should get it. But he couldn't get the Republicans to give him a majority, and the Democrats would not vote for it. What is the problem? What is the problem?
Yeah, good question. And one of the things I do want to be clear on is immigration reform failure has been a bipartisan failure, as you're indicating, right? It has, each side is at different moments not found it in their interest to complete immigration reform. Our last great effort was in 2013, where it actually got through the Senate with bipartisan support. I had 68 votes, I think, when it got through the Senate, got into the House of Representatives, and would have had enough votes to pass the House of Representatives if they ever brought the bill to the floor. If the bill ever came to the floor for a vote, would have had enough votes to pass. Speaker Boehner held it up at the time because it would not have had the majority of the majority. The majority party in the House at that time was the Republicans, and he wasn't bringing any bill that couldn't get a majority of them. They were going to pass it with a lot of Democratic votes and partially Republican. That was unacceptable. That was the last failure when we got really close. But it is, right now, anytime you have one party rule, you usually get pretty far away from it because there's no leverage, and so they can keep just raising the ante, which is what's kind of happened to this point. You had some proposals floated where you had some bipartisan support for money for the wall on the southern border if they gave a permanent DACA fix, and then you suddenly had the White House move the goalposts on that and ask for changes to the legal immigration system. They raised the ante to doing away with what they call chain migration, by which family preferences happened, and doing away with that. And the one thing that a lot of people then pulled back on is, well, we don't want to make the legal immigration system worse. We're going to not do that for here. So we haven't had a particularly opportune moment. One of the things I say to people all the time is, don't ever stop telling your congresspeople and senators what you want here on this. Even though you've got very progressive, if you might have a very progressive person who's very pro this population, wanting to do something for the people who have DACA, Call them frequently, say thank you for their support, let them know it's a priority to you. Because one of the problems is even when you get support, people aren't sure how big a priority that is for the voters and when they'll lose those voters. You remember we had this last, last January, you had the budget resolution where the Republicans needed some Democratic support for the budget resolution. And the Democrats said, well, we want a DACA fix or we'll shut down the government. And the Republicans started saying very publicly, oh, they care about those illegal immigrants more than they care about your federal government. And they're speaking to US citizens. And that scared the heck out of the Democrats. They said, wait a minute, I'm for a DACA fix. I'm not that for it suddenly. We'll pass the budget resolution and let this go. So you've got to let your legislators know it is a top-notch priority to you, sort of like Pope Francis said, so that they hold their ground when they get leverage, that they don't give up that leverage because they get a little scared. And that's the only way we're gonna eventually get this. But I do believe we will eventually get it, because I can't believe in America that we're going to say to those young doctors, go somewhere else and treat patients. You've grown up here, you've gone through our education system, you've passed your boards, we're getting into residency. Why not go back to Mexico or Colombia and treat patients? We don't want you anymore. That's crazy. That's crazy, right? I mean, what sense could that possibly make? So eventually, we're going to have to get this.
I just first wanted to comment that our Oregon senators both have excellent immigration aides who've been doing a lot of stuff both around DACA and generally around, sanctuary status and other things. But I had a separate question for you, which is I was curious in developing your the manual that you were talking about and in your research, have you seen examples of health systems that are particularly welcoming, to immigrants and have been particularly successful? And if you have, then what are some of the key ingredients? I know some of those are in that manual, but I'm just curious.
Yeah, to this point, I haven't seen whole health systems take it on across the board. What I've seen is different health systems say, we have a couple of clinics that have a high prevalence of these patients, and we're going to go talk to those docs and get them engaged in this kind of thing. Largely because I think there's a fear that if you go across a large health system, you're going to have some people who are not on board with this. And then you're going to have patients talking to doctors who are not too happy to be talking about this and probably not helping the patient's situation. And so the idea is to find the places where you have support and buy-in and then roll that out. And again, the key elements are making people feel welcome culturally, trying to make them feel comfortable, and reassuring them that you're really, it's an accompaniment thing. Whatever issues arise, you're going to help them try to find resources. You don't want to, they just don't have to get out of their office because we don't know the answer today. And that's an important thing. If we don't know the answer today, we'll help figure it out. That's what accompaniment is about, right? When we started with these DACA students, we kind of thought we saw a pretty clear path forward, and suddenly we've hit a lot of bumps in the road over the last few years, but they are ours. We are accompanying them further. We're going to figure that out at each step of the way, and that's the key.
I'm wondering if you can clarify, this is going way back to earlier in your presentation around a person's eligibility or ineligibility for benefits, and is it if the person had sufficient funds to purchase a plan on the individual market, could they, or is there a regulatory or legal barrier to them, irrespective of their own resources?
Yeah, the answer is no. On any ACA qualified exchange, even if an undocumented person could pay full price for that plan, they are prohibited by federal law from making that purchase. And that is something where, again, that's my argument for severing this healthcare systems, much like the police system, from immigration status. Because I can't imagine what sense that can make to any of us to prevent them from buying that plan and contributing in advance when we know later on, if they have an injury befall them or whatever, they're going to be in our hospital and we're going to have to use our charity care dollars when they could have paid into that system ahead of time and been covered. So yeah, no, because that's considered a federal benefit to buy even a full price plan.
So even communicable diseases that people are not going to the doctor for can spread.
Right.
So we're shooting ourselves in the foot
Yes.
in the area of communicable diseases, right?
We're shooting ourselves in the foot in every direction here, right?
Well,
Mark, I wonder if you can comment a little bit on the use of language in this area. I feel that in my role as an ethicist, a lot of what I do is listen very closely for language, sometimes reframe. That can be issues in the ICU you were talking about as making some remarks with Dr. Holzgang before about end-of-life care. And are we euthanizing patients, or are we compassionately in some settings recognizing the futility of a situation, the lack of beneficial treatment, and removing non-beneficial medical treatment? So, language has, I think, fundamentally been in the purview of bioethics for some time. And I'm interested in this area, how we see language used, whether or not it's terms associated with illegal aliens, undocumented immigrants, unauthorized migrants, if it's reference points in terms of political debates that cross party lines, or other areas. Do you have any suggestions about medical education in this area, things that should be incorporated into continuing ed programs? Folks have mentioned about diversity programs earlier. What do you see in language in this arena?
Well, and let me actually just turn it back to you. Obviously, you got some suggestions in mind. What do you think?
Okay. I think that oftentimes my goal as an ethicist is to help clarify the moral arguments that are being made, and sometimes that includes moral arguments that I don't agree with, and trying to understand the way in which folks are trying to have a best account of their position can be uncomfortable, right? And sometimes I think that is alluded to in language, how individuals are referring to populations. And what I try to do in my work as an ethicist when this comes up in the setting of an ethics consult or in a discernment around an organizational question is trying to get out some of our biases at the beginning and get to the point where we're in the same boat together, almost a refutation of the tribal politic toward we're now in this together. What are we going to do for our undocumented patient who has a high resource question? How are we going to look at the community benefit dollars we're allocating into this area? Are we doing subtle changes to our the way in which we're talking about charity care dollars versus justice care in a Catholic healthcare system? So I guess it's subtle in my mind, but subtle does not mean unimportant either.
Mm-hmm.
And if I could just add just a general observation of the evolution of the language. When I, years ago, it certainly had negative connotations, but it might have been either consciously or unconsciously invoked, but the term illegal alien was used more frequently. And now, the term undocumented immigrant is more used, and I think it's starting to catch some of that negative connotation. And now, shifting even that terminology to ineligible for benefits descriptors, that's in part the what I found myself challenging, in my role, reframing that to make it more a collaborative conversation rather than, as you say, avoiding the tribalism. I don't know if you have any.
Yeah, no, that's right. And Tina used the word unauthorized immigrant. That's another possibility. The idea of illegal is already judge, jury, and executioner, so we tend to want to avoid that one. And it's also actually somewhat inaccurate because it indicates that the actual immigration to the country was illegal, and that in some cases that's not true. Very often people overstay visas. They actually migrated legally. They're now unauthorized because that authorization was not renewed. So there's accuracy with that. I will say that, as you know, as an ethics consultant, though, we tend to sort these things out, and then you get into a meeting, and people say things you never even anticipated. We have in our second edition of our ethics case book, we report on a case that was one of these questions of an organ transplant for an undocumented patient of ours, and in that meeting, one of the CFO, for reasons unclear to me, he knew he wasn't supposed to say illegals, and so, but he would blurt it out, and then he would say, I mean undocumented. And then after a while, he kept saying, those people kept being the phrase that was used. And you know how uncomfortable it is when you're meeting with a whole table of people, including the CEO, as the ethicist, to have to look at somebody and say, I have to ask you to stop saying that phrase, right? But sometimes you have to. But you will get into situations where people will either be. It's easier if they lack knowledge, because then it's easier to find a subtle way to put the right terms in the conversation. Sometimes people will use it as their way to express hostility, and then as ethicists, we are called on to have a little bit of moral courage even in those uncomfortable situations.
I think the problem could be solved in schools taught native language bilingual. So they're both English-speaking and Spanish-speaking. I mean, it's getting now in Hermiston, Oregon, you can't get a job unless you're bilingual. And we certainly aren't serving the needs of the Mexican Americans by not speaking their language when they come into the hospital, for example. And the two clinics I was involved with, both of the people at the front desk were bilingual.
Yeah, very important, extremely important.
We had Emiliano Zapata. I had one of my artist friends draw a picture of Emiliano Zapata from the family. That drove him crazy. That's the greatest thing in the world. And they had Azteca weavings on the wall. We had a Mexican American, Latin American thing, and they felt comfortable in there. And there was a group of teachers from the Willamette Valley showed up to see a ranch, how they do it. They didn't know a thing about it. I said, well, you're going to see a lot of Mexicans doing the work. And the first thing they said is, we're sending them back to Mexico. I said, how are you going to make that work? Oh, we'll get the gringos to do the work. No.
Right. I think the young lady next to you has a question or a comment.
So just let's say you become next president of the United States. What would you do regarding this issue?
If I became the next president, God forbid.
Next president of the United States. If you become the next after Donald, and then if you become the president of the United States, what would you do regarding this issue?
And again, though, it's going to take building a consensus, because we saw when President Obama was president, he could create DACA by an executive order, but that was not a permanent solution for those young people. And then, of course, anytime you do something by executive power alone, it will face challenges in the courts, which it started to do, and his time ran out. But there does have to be some consensus built around. Again, the 2013 bill was not. It had a lot of bad problems with it. It actually had so much more border security, and it was allocating $40 billion more a year for border security, which was pretty horrible. It's just such overkill. I remember seeing Senator Bob Corker from Tennessee, who I had never heard speak before at the time, saying it was his idea. He said, "But to tell you the truth, this is just overkill," and it was so it had horrible things in it. But what it did for the immigration system was it did a lot. It took care of a lot of the backlog of family reunification that was waiting to happen. It authorized a sort of immediate enabling of those people to get green cards and so on, and sort of expanded certain categories of people to gain authorization, and it kind of put the dreamers on a fast path. They were going to get citizenship quickly. So there's a variety of things that make a lot more sense than what we're doing currently. And I know that right now we're going in an anti-globalization pattern. And right now, but if you look at us, the U.S. and Canada, we don't have a problem of Canadians coming across the border and overstaying their visas, right? Why? Because we have a certain relationship to Canada. There's a certain equality of opportunity on both sides of the border. And so you have a stable relationship, and people from Canada who want to come here typically can. We ultimately need to have that with other nations that are contiguous with us as well and have a land route to the United States. It's difficult when you have a high disparity of economic well-being on both sides of that border, but we have to work to stabilize that. The reason right now our bigger influx is from across our southern borders from Central American nations because of their relative stability there. We're not putting a lot of effort into helping stabilize those nations. And in fact, you can really argue that many of our policies, such as this thing, we always say we want to deport criminals. Well, we've deported them into situations in places like Guatemala where you've got a preponderance of criminals because we have kept deporting all the criminal elements. And so MS-13 that started in LA is rampant in Guatemala, right? And so we have to have a different kind of relationship with those nations. We're actually getting fewer immigrants from Mexico now because Mexico has actually aged up the demographic pyramid. Their demographics are resembling us. Remember I told you old people don't migrate that much? So we've kind of, that's not quite the problem it was. But it is trying to work with foreign policy to stabilize some of those neighbors into a more or less situation where people want to stay home. People are reluctant migrants. And then have a pathway for those who do need to migrate.
So we're at time. Mark, thank you for your conversation and the insights. Thank you very much.